All right, so good evening. Welcome to the Grand Rounds tonight. I'm going to go ahead and share the slides to go through the credits. Let me just swap my presentation. All right, so first and foremost, I would just like to remind the faculty and wherever is joining from, please make sure that the Doximity website is going to be open. And if you receive the link or have the link, you'll be given the link. Please vote for our hospital. This is your own hospital, so that we can climb on the charts. So to get started, tonight's Grand Rounds will be posted at the website. And for getting the CME credits for the session, please text now 20398 to the number 888-816-4893. I'll repeat, 20398. You can send us a SMS text message to the number 888-816-4893. And for getting the MOC credit, we have the link. This will be displayed one more time, again, during the Grand Rounds in the chat box. And you can use the room code Future 2024 to log in and answer the questions. And if the queries are correctly answered, you will get MOC credit that will be directly populated to your ABM ID in the Cloud CME profile. So both the steps for getting your MOC credit points. With that, I'm going to bring in Dr. Yanting Wang and Dr. Michael Wong, who will be panelists for this session. And Dr. Samit Shah will be joining in as our guest speaker. I'll have Dr. Wang introduce Dr. Samit Shah.
Good evening. It is my honor and pleasure to introduce Dr. Samit Shah. Dr. Samit Shah is an assistant professor of medicine at Yale School of Medicine and the Department of Cardiology. He's also the director of the cath lab at the Connecticut Veterans Affairs Hospital. Dr. Shah has been truly, in my vision, a triple threat as a researcher, a clinician, and an educator. And he is a role model for all fellows, including myself. And I have been very grateful to have had the privilege to learn from him. Dr. Shah began his medical career as a basic science researcher. He completed his MD and PhD at the University of Illinois with an extensive background in neuroscience research, especially in molecular signaling underlying peripheral auditory nerve regeneration. He then continued to clinical training at Yale and completed a residency in internal medicine, a fellowship in general cardiology, a fellowship in peripheral vascular medicine and intervention, and lastly, his interventional cardiology fellowship at Yale as well. Dr. Shah has since focused his career on developing precise physiologic and anatomic phenotypes of ischemia and aims to develop targeted therapies for patients including women, veterans, and patients with vasculopathies. He was awarded the Wendy Yu and Thomas Naratel Pioneer Award from the Women's Health Institute at Yale, and is currently the principal investigator of multiple interventional cardiology studies using the VA Cardiovascular Assessment Reporting and Tracking System called CART-CL. Lastly, Dr. Shah has been heavily involved in education on both the national and local level through his involvement in the ACC and SCI. He has coached the Connecticut ACC Jeopardy team year after year and was named the 2022 Linda Rosenfeld Teacher of the Year Award. I'm so glad that he's able to come here and visit us virtually. Dr. Shah.
Dr. Wang, thanks so much for that very generous and kind introduction. And thank you, Dr. Sengupta, for having me today. So my title today is Seeing the Invisible, Ischemia and No Obstructive Coronary Artery Disease. I'll show some cases, and then I'll talk a little bit about the research program that we've developed at Yale, and hopefully give you a different way to view a common problem. My disclosures are research support from Women's Health Research at Yale, Abbott Vascular, and the U.S. Food and Drug Administration. So the background for this talk is that every year, more than 10 million patients are evaluated for chest pain. As cardiologists, this is one of the most common complaints that we will see. 20 to 40% of all people will experience chest pain at some point in their lives. So this is important to us both as clinicians, but also to us personally. And chest pain occurs more frequently in women than men, which I think is a misconception that many of us have. But if you look at ER visits, this is a problem that is either bimodally distributed or weighted towards women. My objectives today are threefold. So number one, by the end of this talk, I hope that you will understand the causes of myocardial ischemia that can occur in the absence of obstructive coronary artery disease. Number two, identify limitations of assessing only epicardial coronary arteries in the assessment of ischemic heart disease. And finally, you can utilize current guideline recommendations for the evaluation of chest pain syndromes, including the invasive assessment of coronary vasomotor disorders. So I have three parts to this talk. So in the first part, I'll set the stage for why I chose this as a focus for my investigation and clinical programs. And then in the second part, I'll talk about the protocol that we have at Yale and what the future looks like. So as I said, chest pain is common. We see many forms of this. Somebody comes in with angina. We describe it as typical, and then they have an infralateral perfusion defect. On their angiogram, they have a tight circumflex. They get treated with a stent. They have a nice result. But then on the other hand, you have people who come in with a normal stress test, severe chest pain. They have an angiogram and they have no ischemia, or they have no coronary disease. And so now we're left with somebody without ischemia and normal coronaries, but significant symptoms. Women are 5 times likely than men to have this syndrome. And there's a huge disparity in the way that these patients are treated. So if you have a PCI, the symptoms resolve, patients feel great, providers feel great, and those patients go on and they're easy to manage. However, if they have open arteries, we describe their symptoms as atypical. We say that they didn't tolerate the medications that we throw at them without knowing what their diagnosis is. And then when they don't feel better, we describe them as anxious. So I'll start off with a case, and then I'll set the foundation for why this is a growing problem. So the first case, a 67-year-old man with traditional cardiovascular risk factors, including hypertension and diabetes, presented to the ER with chest pain and shortness of breath. His initial presentation, he had serial EKGs and troponins, which were negative. As an inpatient, he underwent an exercise stress test, achieved 7.2 METs, and then had reproduction of his presenting chest pain, 5 out of 10 chest pain, and they read the perfusion imaging as inferior ischemia. So he was referred for a diagnostic coronary angiogram. So on his cath, circumflex is normal. The LAD has mild to moderate disease. And then the right coronary has luminal irregularities, but based on the inferior ischemia on the stress, the operator at the time performed an instantaneous wave-free ratio or a non-hyperemic index to assess the physiologic significance of this vessel. It was 0.91, which is above this threshold of 0.89. So no intervention was performed. The patient was managed medically. So he was seen by one of our senior outpatient cardiologists, and so had close care. But over the next 6 months, had 3 more visits for chest pain to the emergency department. He was admitted to the chest pain center. He had a pharmacological stress test, and then as an inpatient, again, in the same year, underwent another coronary angiogram. So this time, the angiogram looks much the same. Another colleague further assesses this LAD disease, and so puts a pressure wire down, and this time does a fractional flow reserve, which was 0.87, well above the threshold for revascularization, and further intervention was deferred. So in the course of a year, this patient had 2 hospital admissions, 5 ER visits for chest pain, 2 coronary angiograms, 2 SPECT stress tests, and then he was eventually referred to GI and had an endoscopy, which was unremarkable. So now on his 3rd admission, he had a note in his chart that said, should he have further a recurrent chest pain, further evaluation for microvascular disease would be warranted. So we bring the patient back, and so this time I have a guide catheter up. The first thing that we do is we inject acetylcholine into his coronary arteries. So this 20 micrograms is the lowest dose that we use. And you see that there's already narrowing. And then at 100 micrograms of acetylcholine, you see that there's really significant vasospasm. So the patient has angiographic evidence of spasm. He has chest pain and EKG changes while he's in spasm. And then we resolve this by injecting nitroglycerin into the coronaries. We then perform further physiologic assessment with a guide wire. We assess coronary thermodilution to look for his coronary flow, and then derive the index of microcirculatory resistance. So his IMR was 31, which is also elevated, and so he has a comorbid diagnosis of microvascular dysfunction. Here you see where a wire is in the distal LAD. So based on this, we were able to give the patient a clear diagnosis, but we changed his medications. We took him off of a couple of things that he was on, put him on high-dose calcium channel blockers for a primary diagnosis of coronary vasospasm. And then when he was seen in follow-up, his discomfort had completely resolved. Even when he had episodes of discomfort, he could reliably take nitroglycerin and had an understanding of what was going on and didn't end up back in the ER. And so this patient now in more than 2 years has not represented. So this syndrome is actually common. If we go back to the Diamond-Forrester description of the pretest likelihood of obstructive coronary artery disease in symptomatic patients, this was published in 1979, a seminal paper in cardiology that informed several iterations of the stable angina guidelines. They describe patients as either having non-anginal chest pain, atypical angina, or typical angina. And then they looked at angiograms and autopsies to try to derive probabilities of people having obstructive coronary artery disease. So the first thing that I want to point out is if you look at typical angina all the way on the right, every age group that was studied, women are at a disadvantage. So a woman who's 40 to 49 years old who presents with typical angina, it's a coin flip whether that person will have obstructive coronary artery disease. And then as you get younger, that gets even worse. And so in this, in people who are 30 to 39 who were included in this study, women who had typical angina, 75% did not have obstructive coronary artery disease. So even in 1979, this was described, but there were, we didn't have the testing to fully understand what was going on. Then if you look at so-called atypical, or now what we call possibly cardiac angina, the numbers are even worse. So women who are 60 to 69 years old, it's again a coin flip whether those women will have obstructive coronary artery disease, but our evaluation of these patients is still focused on obstructive coronary artery disease, knowing that the majority of these patients will not have obstructive coronary disease. I apologize, my lights are on a sensor and I can't fix it. So then more recently, so if you look at the all the catheterizations done in the United States for hospitals participating in the National Cardiovascular Disease Registry, the NCDR database, 400,000 patients. And this was Manesh Panel's seminal paper in the New England Journal of Medicine in 2010. Of those 400,000 patients referred to the cath lab for suspected ischemic heart disease, taking out people who were referred for preoperative reasons or known coronary artery disease, so really de novo evaluations for ischemic heart disease. 59% of patients did not have obstructive disease, and only 38% had a stenosis greater than 70%. If you add stress testing to that, a positive stress test with typical angina marginally increases the percent of patients that were found to have obstructive coronary artery disease. But it just goes to show that in current practice, when we're performing coronary angiograms and the evaluation of ischemic heart disease, obstructive coronary artery disease is not the most common thing that we're going to see. More recently, the Discharge study looked at patients in at 26 European centers who presented with an intermediate pretest probability of coronary artery disease. It was 3,500 patients and 56% women. These patients were randomized to either undergoing computed tomography, coronary CTCA, or invasive coronary angiography. Overall, the focus of the study was actually on what the best strategy is in terms of guiding downstream care. But the most notable finding to me was that the prevalence of obstructive coronary artery disease in these 3,500 patients was only 26%. And so then of those patients, only 14% in the CTA group and 18% in the invasive coronary angiography group were revascularized. And so again, showing us that a significant proportion of the patients who are presenting with chest pain syndromes will have no obstructive coronary artery disease. So if we think about the majority of our practice focusing on atherosclerosis and the prevention and treatment of atherosclerosis, it affects 18 million people in the United States. We have great tools to diagnose and treat. But then there's this entire other side of this where we have patients who, as a spectrum, will also have coronary microvascular dysfunction, coronary vasospasm, symptomatic myocardial bridging. These are often overlooked because they're harder to diagnose. The prevalence of them is unknown, and we're finding that as more programs like ours start, they're increasingly recognized. And when we have a clear diagnosis, we can effectively treat people with medications and lifestyle changes. So to take a step back and just think about nomenclature. So when we talk about ischemic heart disease as a whole, we can break people up into either having stable syndromes or acute syndromes. So the stable patients are the people that we group into INOCA or ANOCA with an A, so ischemia and non-obstructive coronary arteries, or angina and non-obstructive coronary arteries. This is due to either microvascular dysfunction, coronary vasospasm, or symptomatic myocardial bridging. Then on the other hand, we have acute coronary syndromes, and these are the patients who present with either unstable angina, NSTEMI, or STEMI, or pertinent to today's talk, MINOCA, myocardial infarction, and no obstructive coronary artery disease. I'm going to focus mostly on the stable syndromes today. The pathophysiology of MINOCA is a little bit different and includes things like plaque erosion, cardiomyopathies, but will include vasospasm, so we'll touch on it. There's a myth that INOCA is benign, and so sometimes we dismiss these patients because we think coronary artery disease has a worse prognosis. But if we think about symptoms, looking at Seattle Angina questionnaires, the ischemia trial looked at people with coronary artery disease. 13% had non-obstructive coronary artery disease, but people with abnormal stress tests, they had actually pretty high Seattle Angina questionnaire summary scores even before they were randomized to invasive or conservative treatment. Open CTO should be our most symptomatic patients with coronary artery disease, and these patients, again, had a kind of modest reduction in their Seattle Angina questionnaire summary scores. And then Core MICA, which only looked at patients with INOCA, you see they have the lowest Seattle Angina questionnaire summary scores or the highest symptom burden. And I think we've all experienced this in clinical practice, that patients with no obstructive coronary artery disease are often more symptomatic or harder to manage than patients with coronary disease. The prognosis of this is still being defined, and I'll talk more about this later, but some studies have reported up to a 4 times higher hazard of mortality with microvascular dysfunction, but these patients clearly have a significant effect on their symptoms and quality of life. On the same hand, MINOCA is also not benign, so multiple cohort studies have shown a high rate of mortality in people with MINOCA, so greater than 10% at 5 years. So even if somebody has a STEMI and they have a high rate of mortality related to left ventricular dysfunction after that, fatal heart attacks can also occur in the setting of MINOCA. A study out of NYU, HARP MINOCA, showed that if you do further evaluation with intravascular imaging and cardiac MRI, you can get a diagnosis in 85% of these patients, which can be actionable. So to take a step back and just think about this concept of atypical chest pain, this is a quote from a monograph that J. Willis Hurst published in 2001. He said, "We hear words such as atypical chest pain and non-cardiac chest pain as the final diagnosis of patients who have been subjected to several high-tech procedures. Patients know that these words are not diagnoses, as do referring physicians who send their patients for the high-tech procedures. These designations and the lack of resolution renders therapy impossible. Accordingly, the patient's problem remains incompletely addressed, unresolved, and unrelieved." So the second case is a woman who was a 61-year-old woman. She presented with what was described in the chart as atypical chest pain. I want you to hear in her own words what her symptoms sounded like.
Room and was walking down the hall, and I just my heart was pounding. I was having trouble breathing. I'm thinking, I'm out of shape. I got into the next room. By the time I got into the next room, I had this pain, like this pain pressure in my chest. I started sweating profusely. I started shaking. The pain was going across my back, down my arms. And I was like, something's wrong here. This is not just me being out of shape or whatever. So I called.
So one of our medical students for a study funded by the FDA has gone back and interviewed a lot of the patients that we've done further testing on. But I just want to see, I want you to see what this patient experienced with these symptoms that were described as atypical. So on her initial presentation, she goes to the emergency department. She drives herself there. Her troponins come back elevated. And so when she describes this, she'll tell you that they kind of blew her off. But then when the troponins came back, they took her seriously. So this is a high sensitivity troponin T. So her EKG was fairly normal. And then she was rushed to the cath lab based on the troponin and the symptoms. And so initial shot, circumflex and left main are okay. The LAD is tortuous, but otherwise no significant disease that you see there. And then the right has kind of mild to moderate disease distally. So they told her that there might have been a diagonal branch that was missing distally. And so based on that, they started her on dual antiplatelet therapy for her NSTEMI. But she had ongoing symptoms, and she actually presented back to the ER a few months later. A colleague of mine saw her, but instead of sending her for another stress test or back to the cath lab, he referred her directly for physiology testing. So we bring her back to the cath lab, take a different view this time. In her first shot, this time we have a guide catheter up. You see that there's probably a myocardial bridge of the mid to distal LED. We give acetylcholine again. Another case of very clear spasm. We give nitroglycerin, it reverses the spasm. And again, we were able to reproduce her presenting symptoms and then treat her effectively. So actually, a big win in this case is that we were able to take her off of some of the medications that she was on, and we got her completely symptom-free. So she uses nitro patches with activity, but then is on just a calcium channel blocker for maintenance. The third case is this kind of reflects what we all experience in clinical practice with patients coming to the cath lab. So 63-year-old woman, has hypertension, hyperlipidemia, prior stroke, chronic kidney disease, and diabetes. Comes in with anterior ischemia on a stress test. She gets a cath and has moderate LAD disease right where you see the septal come down. So she has a fractional flow reserve, and I apologize for all of the panning that was done in this. And the FFR of the LAD was 0.84. And so initially does well, she's medically managed, but then she comes back 6 months later with unstable angina, and now you see that moderate lesion has progressed significantly, and now there's this calcified significant lesion right where that septal comes off. So she underwent PCI with one drug-eluting stent. She had shockwave lithotripsy. It was an IVUS-guided PCI and had a great result. So then she sees her outpatient cardiologist, and then this is what they write. Since the procedure, she's had continued dyspnea on exertion. She's also had intermittent jaw symptoms. And then they wrote the patient is concerned that she may have an element of vasospasm accounting for her symptoms. And so she gets sent back to the cath lab this time, and the patient presumes she had spasm. And so this time, I was sure that the LED was going to be restenosed, but the stent looks great. So does she have spasm? We do 3 doses of acetylcholine, and she doesn't have spasm. She has mild endothelial dysfunction distally, but no significant vasospasm. We do a resting full cycle ratio, a non-hyperemic index of the LAD where her stent was, and so that was 0.91, and so above the reference range. So this is non-ischemic in the epicardial vessel. And then this screen, again, that you saw before, this is how we assess flow and resistance. So this yellow line is the difference between the distal pressure and the proximal pressure over the course of the entire study that we're doing. The red line is the aortic pressure. The green line is the distal coronary pressure. And then we're doing a fractional flow reserve during adenosine. These white lines coming down are thermodilution injections, and we're doing coronary thermodilution at baseline, and then with hyperemia to derive a coronary flow reserve. So with that, she gets a fractional flow reserve of 0.9 of the epicardial vessel. So her stent, as we said, with the non-hyperemic ratio is fine. The coronary flow reserve is reduced at 1.9. And then the index of microcirculatory resistance is elevated at 36. And then there's a fourth metric here that we use called the resistive reserve ratio, which is the ability for the microvascular bed to dilate. And so she gets a clear diagnosis of coronary microvascular dysfunction after her PCI. And then this is vessel specific in the LAD, so affecting the same territory that brought her to the cath lab, and a clear example of how these syndromes are mixed. It's not just epicardial disease. It's not just microvascular dysfunction. They often exist as a continuum. This syndrome of post-PCI angina is common. Dr. Huang and I can both tell you that it's never satisfying when this happens, but it's not uncommon at all. And if you look at prior trials of revascularization, 20 to 30% of patients who undergo PCI will have residual symptoms at 1 year. So in the second part of this talk, I want to talk about our protocol and the steps that we've taken to make this a scalable study that other people can use at their own institutions. So our entire physiology testing protocol is just kind of based on the biology of the heart. So we focus a lot on the epicardial vessel, but if you take a closer look, there's a very rich network of microvascular vessels. They're important because they control the resistance to blood flow in the heart. And so this concept of coronary autoregulation determines how we're able to maintain resting flow when we're not doing anything, and then increase the amount of blood flow that we need when we're trying to run or to exercise or otherwise exert ourselves. And so we have to have a balance between flow and pressure to maintain the perfusion pressure of the heart. This is a tightly regulated mechanism, and so you'll see a couple of things here. So acetylcholine, then there's others, norepinephrine, nitric oxide, and then adenosine, which we can use as probes. And so I point those out because with these two things, we can test the vascular smooth muscle with adenosine to look at non-endothelium dependent vasodilation. And then we can use acetylcholine to act on the endothelium to test the ability for the endothelium to release nitric oxide. And so that's endothelium dependent vasodilation. And so with the two of these chemical probes, we're able to assess the entire coronary tree. So what we do in practicality, so we bring patients to the cath lab with suspected ischemic heart disease. They undergo a coronary angiogram. The first thing that we do is acetylcholine testing to test for coronary vasospasm. Then after that, we give nitroglycerin to reverse the acetylcholine. And then after they're maximally dilated, we then will do our thermodilution to look at their coronary flow, both with resting conditions and then with adenosine-induced hyperemia. Some technical considerations. And so we have been able to do 80% of these through radial access. We have a low rate of radial to femoral transition. And then we do a few cases that are femoral access just based on anatomy or patient preference. We use 6 French guides for the overwhelming majority of these. Sometimes we get very young patients with small radial arteries, and we'll use 5 French guide catheters if necessary, and we've used a few sheathless guides to make sure that we're able to stay radial. Overall, even including teaching of trainees, the sheath end to end of case time is 56 minutes on average. And then we use about 100 cc's of contrast for these, which is more than a diagnostic angiogram, but includes additional images for acetylcholine, and then getting the wire down for the thermodilution assessment. Our patients, we've done about 250 patients at Yale so far. So the overall pretest probability for coronary artery disease, 53% are intermediate, and then 31% are low, and then the balance, the other 20% are high pretest probability. 92% of the patients that come to us have had a stress test before they come to the cath lab. We're a PET heavy center, and so we have a lot of patients who have had PET stress testing with PET flow reserves. Only 23% of our patients have had a perfusion defect. So many of our patients will have stress testing, but often without ischemia. And so other people have reported the same thing at Mayo Clinic and Stanford. It's about the same. And so this is not a surprising finding to us, but it is notable. The breakdown of diagnoses that we give, so 32% have microvascular dysfunction, 31% have vasospasm, and then 13% will have a mixed syndrome. This group of normal microvascular function is patients who had, this was early on where we just did the microvascular testing part, but didn't test for spasm. And then other includes patients with myocardial bridges or elevated resting flow. One of the most striking things when we look back at our local data is that the time from the first angina episode to diagnosis was 79 months, which is sobering to think that patients were waiting 7 years to get a diagnosis. Notable sex differences. So does this only apply to female patients? No, we also have males that are referred. We had no significant difference in the prevalence of each diagnostic phenotype. So we'll have 80-year-old men who have vasospasm, as well as 33-year-old women who have microvascular dysfunction. We had no significant procedural differences in terms of access or the procedure time. But we did note a lower rate of medical therapy in our female patients. So is this type of testing something that we should do routinely? So this is incorporated now into both US and European guidelines. So in the 2019 ESC chronic coronary syndrome guidelines, this was a 2A recommendation for guide wire testing, and then provocative testing for vasospasm. And then in the 2021 ACC/AHA chest pain guidelines, there's now a 2A recommendation. They did recommend this for patients with at least mild myocardial ischemia. So I hope that in the future that would be resolved based on data that exists and more that's coming out. We published some state-of-the-art reviews in JACC in September of 2023 to help guide program development. And so the first is just defining the problem, discussing the protocol for invasive testing, and then the second part discusses program development and treatment. That's also accompanied by this great meta-analysis by my colleague Yuhei Kobayashi at New York Presbyterian, who talked about the safety of provocative testing with acetylcholine. I think it's a misconception that acetylcholine testing for spasm is unsafe. We found it to be extremely safe, and the data shows that as well. So this is one of the biggest questions that we get is, can't we just guess the diagnosis? And so we all wish that we had a crystal ball and we could just kind of listen to our patients and tell them what they had. So Cormica was a randomized trial in the UK that looked exactly at this. So 150 patients were randomized to either empiric medical therapy or medical therapy based on the invasive coronary function testing. All of the patients underwent the same testing, but the diagnosis was blinded in the control arm. So a little bit more about Cormica. After the randomization, they looked at quality of life and symptom assessment with the Seattle Angina Questionnaire. So patients where they had disclosure of the diagnosis and medical therapy based on that had significant improvement in their angina and quality of life. And this is historically a very challenging population to treat. And so if you look at their Seattle Angina Questionnaire summary scores, and I alluded to this before, they're very low at baseline. But when the diagnosis is disclosed, probably both due to disclosure of the diagnosis, but also based on changes in their medical therapy, you see a significant improvement in their Seattle Angina Questionnaire summary score at 6 months, and then again at 12 months. Same with the European Quality of Life, EQ5D5L. So how should we treat our patients? This is loosely taken from Cormica. So patients with vasospasm as a confirmed diagnosis, we prioritize calcium channel blockers and then short-acting nitrates. Long-acting nitrates like isosorbide mononitrate have not been super effective. We've had a few people who have done well with isosorbide dinitrate. And then with refractory patients, stellate ganglion blockade has been a very effective adjunct therapy. Microvascular dysfunction is best treated with beta blockers and cardiac rehab. ACE inhibitors and statins are being studied in the Warrior trial, and then smoking cessation for both groups. And then the last part of this that we don't talk about a lot, but if we can give patients a diagnosis of non-cardiac chest pain after doing a thorough physiologic assessment, and we're very confident in this diagnosis, we can actually take patients off of anti-anginal therapy and then refer them to the appropriate specialty to help figure out what their symptoms are. I think it's harder for us as cardiologists to say that it's a GI problem if there's still the specter of a possible underlying cardiac problem. But once we are very sure that it's not a cardiac diagnosis, it's easier to send them to a different specialty to be further evaluated. So this is what our patients say, and our data will suggest the same, but just some testimonials. So patients, it's really rewarding. They write back and they feel great. And so, you take care of a patient with a STEMI, they thank you, they shake your hand, but when somebody's been suffering for 7 years and you finally give them a diagnosis and symptom relief, people are really grateful. So this is really the reason that we do this and why we have a whole field of investigation in this area to help improve the quality of life and symptoms of our patients. So in the last part of this talk, I'll talk about what the future looks like and some of our investigative efforts. So I hope I've convinced you today that this paradigm of ischemic heart disease should now include obstructive coronary artery disease, as well as less recognized syndromes like microvascular dysfunction, coronary vasospasm, mixed disorders that are a little bit harder to tease out, and then other things like mental stress-induced myocardial ischemia, myocardial bridging, and elevated resting flow, which we can test for and give a name to so we can help better guide therapy in the future. If we were to think about the work that we've done and seen with our patients from a clinical practice standpoint and identify knowledge gaps, this is what we came up with. So we first said that we need to develop a standardized protocol that can be performed at other medical centers. So I think it's not helpful to only be able to do this at very tertiary or quaternary centers, but to be able to scale this so all of our patients can benefit. We need prospective definitions of phenotypes. I think microvascular dysfunction to me may not be the same as to Dr. Wang or to Dr. Huang. And so to have clear definitions based on data helps all of us as a field communicate. And then we need to know what the prognosis is, both in terms of patient-reported outcomes and in terms of hard outcomes. So just because somebody doesn't die of a fatal MI doesn't mean that they're not suffering. And so I think as cardiologists, this is why a lot of us went into cardiology, is to take care of people both for symptom relief and for prognosis. So some of the work that we're doing, this is currently under review, circulation. And so to define the hazard, we have a meta-analysis of 17,300 patients. We stratified patients based on the Covadis criteria definitions into vasospasm or microvascular angina. And so based on these two groups, we wanted to know what the long-term hazard is. And so the first point to make is that we all recognize that the data in this field has been very heterogeneous. And so it's hard to actually look at studies and put them as apples to apples. But we meticulously combed through them to try to come up with clear definitions. So people with vasospastic angina had a rate of all-cause death and MI of 0.7 in 100 patient years, which was lower than patients with microvascular dysfunction, which was 1.1 in 100 patient years. This asterisk on this microvascular dysfunction part is that if somebody has a reduced coronary flow reserve, that group has the worst prognosis. You see our forest plot here showing the hazard over time. So as patients get out from the time of their diagnosis, over long-term follow-up, the hazard increases. And so there is a long-term hard outcome hazard. It's not super high. So this is actually reassuring in some ways that we can tell our patients with spasm, for example, that they actually have a great prognosis in terms of hard outcomes. But we also know that there's work to do in terms of further understanding why these patients with microvascular dysfunction or a low coronary flow reserve have a worse outcome. So that sets the stage for Discover ANOCA, which I'm really proud of. So this is a prospective multi-center registry where we're enrolling 500 patients at 10 centers. We're well underway. We're taking patients with suspected ischemic heart disease who are referred to the cath lab for clinical indications. And then they undergo a standardized protocol, including coronary angiography, acetylcholine testing, physiologic assessment, as I demonstrated with thermodilution to look for coronary flow reserve and the index of microcirculatory resistance. And then by protocol, mandated intravascular imaging to assess for plaque burden and myocardial bridges that may have not been angiographically evident. We're assessing symptoms both at baseline, so before a patient undergoes any testing, they're consented, and then they have patient-reported outcome measures as well as a symptom assessment. And then after their testing, we're following patients for 5 years, and we have serial assessment of both the hard outcomes through a centralized call center, as well as patient-reported outcomes. And so we get granular data on what's happening to the patients in terms of rehospitalization, but also what their symptoms look like. And so we've enrolled 106 patients so far, and the data has been really remarkable. We'll be presenting the initial interim data at SCAI in May as an oral presentation with a simultaneous publication of the design and rationale. Additional work that we're doing, so to try to define the patient-reported outcome hazard of this, we wanted to go back and start over. So if you look at the Seattle Angina Questionnaire, that was developed on a sample that was 97% men. But as I mentioned before, many of these patients are women. And so one of our medical students interviewed 50 of our women with ANOCA who underwent physiology testing. So it's 35 hours of interviews. Our team then went and transcribed these interviews, and then we coded them for common themes. And so we have very granular data on what our patients are reporting. And the goal of this is that we have a draft now of a new patient-reported outcome measure developed specifically from women, which I think is the first time for a cardiovascular patient-reported outcome measure, but developed on this patient population of ANOCA. Here are some quotes of what our patients say. I feared for my life and it was paralyzing. I felt like no one was believing me and I doubted myself. And this sentiment of invalidation is pervasive. Almost all of our patients said this. And so I think as cardiologists, we go to work wanting to do our best for our patients, but it's challenging when we can't see what our diagnoses are. And this is what one of our patients said. This is what our symptoms feel like.
The symptoms were like a heart attack to me at the time. Yeah, so chest pain and difficulty breathing. And yeah, I felt like I was dying. So I went to ER. That's how it started.
So we may describe these symptoms as atypical. We may blow them off after they've had a normal coronary angiogram. But what we have found when you take a close look at patients' symptoms, that they are very clearly cardiac symptoms. And we just need better instruments to be able to formally assess patients. These are word clouds, and so to that effect, so if you look at the symptoms that patients reported, if I showed this to any cardiologist, we would say these are clearly anginal symptoms. If you look at the physical limitations that patients have, these are the same limitations that patients have when they have a 90% lesion in their proximal LAD, but these are patients with open arteries. The functional limitations, they're clearly affecting key parts of their life, including life, quality of life at home, work, social activities, travel. And then we further looked at psychological impact and their perception of illness as well. The last study that I'll show you, and so this is a study that's also under review, and so looking at real world practice. So if we look back at our practice at Yale, specifically looking at women who underwent coronary angiography with or without coronary function testing for suspected ischemic heart disease, we took a simple random sample of our patients, and so patients with angiography alone in the red here, and then patients who underwent coronary function testing in the blue. 99 women in each group. So the patients in the red group, the average age was 62, slightly older than our patients who underwent coronary function testing, which was 57. 71% of these patients that underwent angiography alone had an abnormal stress test compared to only 41% in the coronary function testing group. And part of the reason is that a lot of these patients underwent coronary CTA first. And then if we look at the diagnoses that we give patients, so we just do an angiogram, 21% will get a diagnosis of normal coronary arteries, 79% received a diagnosis of non-obstructive coronary artery disease. The patients who underwent coronary function testing, 49% had normal coronary arteries and 51% had non-obstructive coronary artery disease. Our standard of care is to leave it at this, but then in the coronary function testing group, we take it one step further, and so now we have a physiologic diagnosis. So 27% had microvascular dysfunction, 32% had vasospasm, 16% had a mixed syndrome, and then 4% had symptomatic myocardial bridges. The outcome of all of this is that if you look at medication changes, both at 24 hours and at 30 days, there's a significantly higher rate of medication changes in the coronary function testing group. So once you give somebody a clear diagnosis, you're much more likely to change their medications, both at 24 hours and at 30 days. And this is reflective of what we do with these patients. So if you have a cath and you only look at the middle column here, once they have this diagnosis of non-obstructive coronary artery disease, we essentially dismiss them from cardiovascular care. They have very little titration of their anti-anginal therapy, and we're often not sure what to do with them. When you have a clear diagnosis based on coronary function testing, we do titrate their medications. And then to take a closer look at this, what we actually do is there was no change in the preventative therapy, but there was intensification of the anti-anginal therapy. And so at 24 hours and at 30 days, the group that had coronary function testing had a significantly higher rate of change in their anti-anginal therapy, specifically with a significantly higher use of calcium channel blockers. So I think the limitation is that this is single center data, but it is reflective. Our program is decentralized. So once they come in, we just do their physiology testing. We don't follow them in our clinic specifically longitudinally. And so we're not making these medication changes. It's their referring provider who's making the change. But it's easier to make a diagnosis or to make a medication change once you have a clear diagnosis. So I'll end here. And so in conclusion, I hope I've made the point today that chest pain is common, but patients without obstructive coronary artery disease are often left without a diagnosis. In roughly 50% of the patients who are referred to the cath lab, ischemic heart disease may refer to a disease process that does not include atherosclerosis. And then coronary function testing can help define diagnoses such as microvascular dysfunction, vasospasm, or myocardial bridging, which we can adequately treat with targeted medical therapy, leading to improvement in quality of life and symptoms. It's taken a village for us to get to this point. We have a really well-oiled machine in terms of our coronary function testing program, and I have a lot of people to thank, both for the clinical program and our research enterprise. And I thank you all for your time today, and I hope I was able to share some helpful information. And then this is our update on Discover and OCA. We had a good week last week, so we're at 106 now. And so more to come on a prospective study of this patient population. So I'll gladly take any questions that you have.
Thank you, Dr. Shah, for this very excellent talk. You had mentioned about stress-induced ischemia. Can you elaborate further? How do we treat that? When should we look for that? How do you test for it? And my second part of the question is talking more about microvascular dysfunction. Has there been any research or any thoughts about expanding its use into our transplant population, as a lot of these patients after transplant are getting catheterizations to look for graft disease. So, thoughts about that, and then I'll circle back. I think we have a couple of questions from the chat box, but just to start off with those two.
Yeah, so Dr. Wang, fantastic question. So the stress part is near and dear to both you and I. I think I remember you scrubbing into one of our mental stress studies. So just some background on my start in this area, which when I was a second-year cardiology fellow, somebody prompted me about what I wanted to do. And I said, I want to do device-based translational research. And so I got looped into this study doing mental stress testing in the cath lab. So what we were doing is we would bring people to the cath lab, put a pressure wire in their LAD usually, and then we had a health psychologist come in and ask them math questions on the table. And so while we're doing this, we're doing thermodilution to assess their coronary flow reserve, both at rest and then during adenosine, and then finally during mental stress. And so the question was, what happens to the minimally achievable microvascular resistance? And so there's this syndrome of mental stress-induced myocardial ischemia that's been described in the non-invasive literature for many years. And Alan Young has a paper from 1989 in the New England Journal of Medicine about this. So it was a mechanistic study, and what we wanted to see was what would happen to their microvascular resistance during stress. So in 30% of patients, when they're under stress, their microcirculatory resistance goes up and their coronary flow reserve goes down. This is different than physical stress, where we should decrease our microcirculatory resistance and perfuse our hearts so we can run away from the bear that's chasing us or do whatever activity we're doing. This syndrome of mental stress-induced myocardial ischemia is pathologic because there's a subset of patients who increase their microvascular resistance, reduce perfusion, and they get symptoms in that regard. So as a trainee, this was really, it was a kind of enlightening thing, because I said, like, this is not a static problem that we're dealing with. We think of patients that come to us with angina, and we're used to thinking about it as, a fixed obstruction, like there's a clear problem reducing blood flow. And seeing it in person in real time, that you can dynamically change somebody's coronary flow, really led to the rest of the work that we've then done and what I presented today. So that's the part about mental stress. I think we all recognize this, even in the stable angina guidelines, psychological stress is given equal weight to exertional stress. And so it's a clear cause of angina, so not to be dismissed. Your second question was about microvascular dysfunction in transplant patients. And so the hallmark of transplant vasculopathy is that it affects both the epicardial vessels, but also the microvascular vessels with equal intensity. So we'll see it on an angiogram or by imaging in the epicardial vessels, but we know that at that time it's also happening in the microvascular bed, and that's why it's so devastating once you really see the onset of transplant vasculopathy. All the data in this area comes out of Stanford. So Bill Fearon, who led the FAME trials and has really been seminal in kind of developing invasive assessment of microvascular dysfunction, has demonstrated that an elevated microcirculatory resistance in transplant patients is by far one of the most prognostic indices that you can use. So if you have somebody that has perfectly looking epicardial vessels, but a high microcirculatory resistance after transplant, that in itself is prognostic. And so it's telling you that over the next 5 years, that patient's transplant may fail because of the onset of transplant vasculopathy. I think it's a hard sell to convince every patient that's undergone a transplant to then have a cath where you put a guide up and put a wire down. But I think in the future, we're going to have non-invasive assessments of microvascular resistance from the angiogram alone. And I think it's a kind of exciting way to further risk stratify this patient population going forward.
Thank you.
Dr. Shah, thank you for this great overview of this talk. I saw that a lot of our fellows are on, so I think this is a great teaching, about this very difficult to teach topic, but I think you presented it very well. I had a couple questions. I'm an interventional cardiologist, just like Dr. Chaudhry, who posted a question. We were talking about this before. My question is, do you feel that, physiologic testing, is it ready for sort of all interventional cardiologists, or should we kind of limit it to, center of excellence, where it's sort of referred in after normal clean caths, and, have, specific interventionalists who are capable of interpreting these studies like you are, and not just kind of run it?
So I a lot of the data I've shown, I'm standing on the shoulder of giants. So people have been doing this for 10 years. And so Mayo Clinic, Cedars-Sinai with the WISE studies, they've been doing this for a long time. Our innovation, I think, is that we've made this pretty user-friendly. And so I can do this, and without a fellow, I think we timed it. It's like somewhere around 17 to 25 minutes or something like that. And so we can do it pretty rapidly. It's an angiogram. You inject 3 doses of acetylcholine, which takes about 5 minutes. And then the thermodilution, you know, I think for an attending to put up a guide and put a pressure wire down is not a huge amount of time. And so I think we are finally at the point where we can scale this, and this is what we're seeing. So on a weekly basis, I get phone calls from around the country or emails with people asking for our protocols, asking for things like that. And it's just, you know, it's not just academic centers. We're not just getting centers of excellence, but we're getting hospitals all over the place that are taking care of these patients, and they are reading the literature that comes out, but they're seeing that they're able to do this. So I think the technology is now there. There's some, I think Dr. Chowdhury also asked about this, the capital expenditure about doing ChloraFlow testing. Just to separate the two, so acetylcholine is a drug, it's an eye drop, and I have to disclose that this is an off-label use of an eye drop. And then that's for vasospasm. And then the wire-based testing, Abbott Vascular has a proprietary wire that they bought from St. Jude. And so you have to make some proprietary investment in that. The Abbott is actually pretty aggressive about a disposables agreement. So I think at our VA hospital, we got it early on, and we were doing 6 wires a month or something like that to cover the capital expenditure. At Yale, we bought it as a capital outlay. So I think there's many ways to do it to get it in. But I will tell you, in terms of volume, I do on a single day in the Yale Cath Lab, specifically devoted to do this, I do 12 of these a month. And then I see a lot of outpatients where I don't do the testing. And so there's more than enough patients to justify the use of this. And so I think a hospital administrator, the business case is easy. These are often patients who also get downstream testing. And so I think once you're able to bring them in, it adds to your patient population.
And how are the payers with approval of this testing?
So I would tell you it's about 10% that get where I have to do a prior auth. But often, by the time it gets to a peer-to-peer, if you say the word fractional flow reserve, they immediately rubber stamp it and it gets through. I've had one out of, like I said, 250 that was outright denied. And the actual peer-to-peer person said that they totally agree with it, but the person's specific plan just basically didn't allow for it. And so in general, the payers are okay. And I wonder when insurance companies are going to realize that if they do this, they're actually going to save costs. So Mayo Clinic did a cost analysis of this, and per patient, you're saving $23,000 per year in terms of additional testing, like stress testing.
Stress tests and everything else.
Repeat cath and things like that. Yeah.
Right.
So I'll read some questions that from the chat box. Dr. Hamarani and Dr. Maganti are 2 non-invasive cardiologists here. Based on your experience, do you suggest people get invasive as well as non-invasive assessment, or just invasive assessment of ANOCA? And what do you think about stress PET imaging in this population?
So I have a slide that I didn't include today, and it talks about our sources of referral. So part of, I talk about the science and the clinical relevance, but also in terms of the program building. And so our referrals actually come from a pretty wide stretch, but often from our non-invasive colleagues and often from the stress lab. If you think about this, so we have a monthly cath nuclear correlation conference. You take a stress test and they have a perfusion defect, and then they show the angiogram and it's normal. Is that an accurate defect on a PET stress test related to microvascular dysfunction, or is that a false positive stress test? So our nuclear community has really embraced this. They actually find it very beneficial. And then the other part is that somebody who has a perfusion test that's normal, and then they get a cath, it's helpful to see if they actually had vasospasm as the underlying diagnosis. So the invasive part is complementary to the non-invasive part. As an institution, we've had a learning curve. And so you get a rubidium PET myocardial flow reserve that's reduced. And we say, yes, is that microvascular dysfunction? I think often what we'll say is it could be balanced ischemia, it could be microvascular dysfunction. But then over time, we've become much more confident in our ability to say this person has no coronary calcium, they had normal perfusion, and then now they have a low myocardial flow reserve on their PET stress test. And so that patient has a clear diagnosis of microvascular dysfunction. So rather than sending them to the cath lab, if anything, you would do a CTA and stop there. But that only happened because we would send people to the cath lab and then do their invasive testing and show the same result. And so we have a SCI abstract accepted showing the correlation between our PET myocardial flow reserve in our invasive assessment, and it's 91% concordant, or something like that. So it strengthens, I think, the rationale for doing both testing, both the non-invasive and the invasive part. And so it's better for our patients too than for serial assessment, or to spare people from having an invasive procedure that they may not need.
Thank you. I have there's several questions in the chat box. Dr. Cormelis has asked, is acetylcholine sufficient to rule out coronary vasospasm? And is there a role for organovine?
Yeah, so I have a reference, and I Dr. Chowdhury asked about protocols and things, and I'm glad to share all of our protocols with you as well as the key references. And so I challenge everyone to look up the test characteristics of acetylcholine testing for coronary vasospasm. It's somewhere above 95% specificity and sensitivity, which beats any other test that we have for ischemic heart disease. And so it's really, acetylcholine, I think, gets this bad reputation that, oh, if you inject acetylcholine in everyone, they're going to spasm. But it's really not the case. And if you look at our patients, it's only 30% who spasm. The rest of the patients either vasodilate or may have endothelial dysfunction or no change at all. Organovine has gone out of favor because of the safety profile. So if you have contrast in your syringe and you have organovine that you're injecting intracoronary, there's a high risk of ventricular fibrillation. And really, it went out of favor in the early 2000s because of safety events. And so acetylcholine has been shown to be a lot safer. The half-life is shorter, and so it's out of the patient's system. So even if they're bradycardic, they go back to normal sinus rhythm very quickly. And so we've found it to be pretty easy to use acetylcholine. And I think that's kind of where the field has gone. And so if you look at our JACC state-of-the-art review, we basically only talk about acetylcholine for that reason. I know of 2 centers that have brought methyl organovine back because of a challenge getting acetylcholine, but otherwise the overwhelming majority of centers, which is somewhere over 50 now, is doing acetylcholine testing.
All right. Another bundled question. This is about the Warrior trial. The Warrior trial recently conducted prescribed patients based off of symptoms after ruling out obstructive coronary artery disease without performing testing to assess for ischemia. What are your thoughts about that? And part 2, what is happening with the PRIZE, where ET1 gene testing is being done, and the Warrior trials? Looking forward to those results and to help us tailor the treatment for these patients.
Yeah, so great question. So Warrior is a prognostic study, and I think it's an important distinction to make. I talked to Noel Berry-Mertz about this a few weeks ago, and so if you think about what I reported as the hazard of both microvascular dysfunction and vasospasm, if you have a low hazard of hard endpoints, Warrior is going to look at medications to really improve people's outcome, including aspirin, statins, and then ACE inhibitors or ARBs. I don't know if we're going to see a positive effect in that because the baseline hard endpoint result is so low. So these patients are symptomatic, but they're not necessarily having major adverse cardiovascular events. The patients in WISE who had these events had comorbid atherosclerosis. And so once you've ruled out obstructive coronary disease, which is the population in Warrior, but they have ischemia on a non-invasive test, will we see an effect? I'm not sure what we're going to see, but there's no further testing for ischemia down the road, and there's also no symptom assessment. So I think this is a challenging study. They had trouble enrolling, but I'm excited to see the results because I think anything that we can do to improve the prognosis in this population is helpful. So PRIZE is zibotentan in patients who underwent genetic testing with microvascular dysfunction. So again, another study that's been hard to enroll in because every patient has to have a specific genotype. So it's 2 innovations. So number 1, it's progress in terms of anti-anginal therapy for people with microvascular dysfunction, but then it's also pharmacogenomics for guiding medical therapy. It's a black box to me. I think we're going to see what it shows, but I'm not sure. I hope it's positive because then we'll have a patient population that may benefit. But again, now we're taking all of these people with microvascular dysfunction. We're saying we have to do genetic testing, and then based on that genetic testing, we'll have people with this ET1 gene mutation where they may benefit. And so I think it's a step in the right direction, but it's a clear sign that we need investment into novel therapies. The last anti-anginal therapy that was released was ranolazine, and just this year we finally had the first study that actually showed a population where it works, and it's only people with a reduced coronary flow reserve.
And I have a question from Dr. East. Is there any evidence to suggest that the process is reversible? For instance, if a patient with diabetes gets their A1C under control, does the coronary flow reserve and/or symptoms improve?
So the evidence, I think, for coronary flow reserve is a little bit different. I think there's studies that have through non-invasive methods, but with cyclotrons and ideal radioisotopes like nitrogen-13 ammonia, looked at people with hyperlipidemia, for example, and if you control their lipids better, their coronary flow reserve goes up. So I think as you improve endothelial function, the coronary flow reserve can go up. In terms of people who are symptomatic with ANOCA syndromes and they have microvascular dysfunction or spasm, I'm not sure. I think, people talk about this concept of putting somebody on a calcium channel blocker and re-challenging them with acetylcholine to see if it prevents spasm. To me, I would only do that if they had ongoing symptoms and we wanted to see what the mechanism of their symptoms were. So maybe there's a comorbid pain disorder or something like that that goes with it. But otherwise, in our cohort, we have not re-challenged anyone. But I do think that there's good quality data, especially from the nuclear literature, about diabetes and improving glycemic control and improving coronary flow reserve. And then I think the key point is that with a better coronary flow reserve, the long-term prognosis is better.
Thank you. Dr. Huang, do you have any other questions?
No, I think this is a very, very thorough review and a lot of good interesting questions that I think will kind of provide us, and hopefully we'll get this physiology testing program started here at Robert Wood.
Yeah, let me know if you want any help. We started, our first one was 2016. And so now 8 years later, it's like this, it's gone. I mean, I booked these like weeks out. And so it's really skyrocketed, and it's led to a lot of research funding and things like that. So it's been a great journey so far. And then I'm excited to actually start sharing some of the results that we've had. Dr. Chowdhury also asked about continuing medications. So we have a lot of patients who are like 30, 40, 50 years old, and they want to come off their medications. But I say to them, like, you finally feel good. So let's start with that. And then I don't know what, I mean, maybe in the future we'll get them off. I think the best case for getting people off is people with microvascular dysfunction who complete cardiac rehab. We can sometimes get them off of some of their medications, but I don't often recommend peeling them off of their medications if they feel better.
Great. So I think they're looking for me to come back, and I'm not in the spotlight, but all three of you are in the spotlight and you've done great. So we will look forward to Dr. Shah. We'll take your guidance and maybe have you come and visit us, and we'll see how we can set up the lab here. We're really, really interested to bring this into not only the research side, but also for the clinical care aspect. And I really enjoyed your perspective of both how it can not only bring up the academic side of unknowns and the opportunities, but also it I believe is a big attraction for a healthcare system to see that there are lots of patients who really are looking for answers, and we do not have typical answers on the routine testing that is done. So really, that's it's wonderful. And I have more questions, but I think in the interest of time, maybe we'll personally connect, and then we'll have you come and visit us and guide us on how we can set this up here.
Thanks so much for having me today. Your great questions. It was really a great experience, and I would love to visit you in person.
Great. Thank you very much.
Thank you.
Bye-bye.
Great to see you. Bye-bye.
Good night.